Good afternoon, network. Welcome to today's echo session. We'll be starting shortly. Just waiting for a few more participants to join, and then we'll be starting probably in the next 2 to 3 minutes. Thank you for joining us today. Let's see, there's David Chilufia. Thank you for joining us. Dr. Chitalu. Sister Nkonde, thanks for joining today.
Recording in progress.
Can you hear us clearly?
Yes, Doc, we can hear you.
Great, thank you. We're just having an issue with a few more people joining in. Some issue with the registration link. So we're trying to just fix that very quickly so more people can join us and we can have a nice collective decision. Good afternoon, ladies and gentlemen. Thank you so much for joining us today. It's a nice sunny day at the Institute of Digital Health. So we're about to start our session. First of all, I'd like to thank everybody for joining us so far. We're hoping to have a very nice discussion regarding the advanced HIV disease on today's echo session. So this echo session is brought to you by the Ministry of Health in collaboration with ZACOF. So once again, you're very, very welcome. So just a few house rules before we start. Make sure your microphones are muted. Your cameras are on so that we know you're all there and participating. And if you have any questions, kindly raise your hand or post in the chat box and we shall be able to attend to them. So we have a very, very interesting topic today, which is the deep mycosis. And this is going to be presented by our one and only Dr. Sombo Fwoloshi, who is our infectious disease physician. Thank you so much for joining us, Dr. Fwoloshi. So Dr. Sombo will be taking us through the deep mycosis presentation, and we're being joined by our panel of experts today. So we have Dr. Chitalu Chanda, who's an infectious disease physician, Dr. Duncan Chanda, and Professor Lottie Hachambwa, who will be joining us shortly, along with the ZACOF team. So we're looking forward to having a very interesting discussion. Kindly pay attention so that we learn from all ends and have this great discussion. So I shall hand over to our presenter, Dr. Sombo Fwoloshi. So over to you.
Thank you, Dr. Naik. Good afternoon, everyone. Thank you for joining us for today's session. My name is Sombo Fwoloshi, but importantly, I'm joined by colleagues such as Dr. Chitalu Chanda, Dr. Makai, Dr. Andrew Zulu. These are helping the ID team build the next generation of infectious disease physicians. So to start off, these are our objectives. I'll outline the classification of the deep mycosis. I'll describe the epidemiology and also summarize some of the clinical characteristics of selected deep mycosis. Particularly, I will focus on histoplasmosis. I'll mention why in a minute. I'll also talk about the considerations in patients with advanced HIV disease. What are the challenges, the opportunities, and what do the WHO and the Zambian guidelines say about this? First off, please let's take this to be a primer. Mycosis is an extremely wide area in infectious diseases, and I will stick to the ethos of ECHO, which is low dose, high frequency. So we will have more sessions and chip in on and zero in on some of the mycosis. So please do not feel overwhelmed. It's quite a broad topic. I have just summarized on one critical one for AHD. Yeah. So we'll start off with a poll question.
Thanks a lot. This sounds really exciting already. So I'm just going to launch our poll questions really quickly, and then I can read out the question to you. So, oh, no. Poll. Sorry, that's poll question one. Can you launch a poll question? Okay, so our first poll question reads, all of the following are characteristics of systemic mycosis or deep mycosis except, we have option A, most of the dimorphic fungi cause the infection. Option B, pathogenesis mostly occurs due to the inhalation of spores. Option C, opportunistic fungal infections are the only example of deep mycosis. So the question is, all of the following are the characteristics of systemic mycosis or deep mycosis except. Option A, most of the dimorphic fungi cause the infection. Option B, pathogenesis mostly occurs due to the inhalation of spores. Option C, opportunistic fungal infections are the only example of deep mycosis. So let's all ensure we attempt the MCQ questions. Is it? I don't know. Okay, great. So Dr. Fwoloshi, we have 60% that have opted for option C. Opportunistic fungal infections are the only example of deep mycosis. And then 20% that are opted for aspergillosis and mucormycosis are the systemic mycosis. Option B, pathogenesis mostly occurs due to the inhalation of spores, 17% for that. It will be interesting to see what we get along the way.
All right, don't worry about it. I know we have something different on the screen and there, but it's not an issue. So I will touch on the general concept. We only have an hour. So mycosis are classified based in based on four classifications broadly. You can classify them based on the site, which is are they superficial, cutaneous, subcutaneous, or systemic. So the deep mycosis are also referred to as the systemic mycosis, and these are the ones we're interested in. So in terms of the superficial, cutaneous, and subcutaneous, you can think of some such as ringworms. Most of these will be seen in the dermatology clinic. Things like mycetoma, which are very deep fungal infections, which are in the subcutaneous tissue, may also present themselves at the skin clinic. And usually they are foot, but can occur on the back. But this is for the subcutaneous. Sometimes we actually classify them based on the route of acquisition. Are they exogenous or endogenous? That is, did you inhale them from the environment or through inoculation into your skin? But some of it may be endogenous, meaning you are already colonized, particularly things like Candida, by a member of the normal flora or reactivation of a previous infection. Sometimes we classify them based on virulence, and this was the poll question. So you can see that opportunistic fungi, or opportunistic mycosis are the ones that occur in the compromised host, but also they can be primary in those that and can establish infection in the normal hosts. And again, settling in on histoplasmosis. Before HIV tended to be a primary pathogen, but now it has emerged very clearly as an opportunistic infection in people with advanced HIV disease. So some can be primary, others can be opportunistic. In terms of epidemiology, so do they occur in relatively well-defined geographic areas? So the opportunistic ones tend to be ubiquitous. So things like cryptococcal meningitis, cryptococcus is all over the environment. Others can be confined to certain regions of the world. But of course, this depends on the studies done. And most of these studies are done in Latin America and Asia. So you will find that they said they'll call them endemic fungi. So they are localized in those areas, well-defined areas. And these tend to be primary. Whereas the opportunistic ones, they're all over. Crypto is a very good example. So just to show how they behave when we say, I think there was a question on whether they are dimorphic. What we mean by dimorphic? Okay, so you can see that the fungi takes up two morphologies and phenotypes. The way it will look in the lab depends on your temperature. And these temperatures, you can see there's a gap, right? It's not less than 25, more than 25. So in vivo, meaning temperatures that are closer to the human body, they become yeast. While in temperatures that are cold, they become molds. And this is very important. Today, I was speaking to my friend who's a microbiologist, and he said, for these types of things, you actually need specific labs because the molds are the ones that will bud off and the spores are what you inhale and infectious. And this can pose a threat to people in the lab. But the diagnosis in vitro, you can see the morphology, like blasto tends to have this big, what they call, these big yeast, they are macronidia. While histoplasma, you can see the mold is, it's thick with a very rough edge, but this is laved up. And this is how they multiply. You can see that it forms a budding yeast. Just to mention that at the bottom, this is the behavior of Candida. So in the lab, they would say, we have seen germ tube formation. It is very classic of Candida. So this is just to to show people what happens in the lab. So for Cryptococcus, it's not up here. You see the yeast and everything. It's discouraged to grow these organisms in the lab. Crypto is quite friendly, but these others, because the lab people can actually inhale it. So you actually require a biosafety level 3 lab, just like for TB. So these are the sites of infections principally. You can see it likes the brains, the lung, the heart, the liver, the kidney, the spleen. While the superficial will be your nails, your skin, and your hair, and the subcutaneous tissue. So the primary systemic pathogens of interest is Histoplasma capsulatum, while opportunistic fungi are things like Cryptococcus neoformans. Of course, we see most of these, but the issue with our setting is diagnostic capacity. So we are unable to make most of these diagnosis. So one of the important opportunistic fungi in people with advanced HIV disease is Penicillium manifii. You can point at it, this one. The name has changed to Terraromyces or something like that. But Penicillium manifii is very common in Asia, actually Southeast Asia, and it may look like a TB, but it needs antifungals. So this goes to support the notion that we need more stewardship in terms of diagnostic stewardship. I'm sure we are all aware that this week is actually World Antimicrobial Awareness Week. And one of the issues that has been driving our antimicrobial resistance is giving antibiotics, unnecessary antibiotics in people with HIV. And the limitation with that is that we just have limited diagnostics. So histoplasmosis is a primary mycosis. It does not require an immunocompromised host. So it's one of the diseases that was there before HIV came. And mostly it's actually asymptomatic or a clinically mild infection. Normal patients, normal hosts can have it. And typically people who have traveled to endemic areas such as Asia, Latin America, and Africa. And these patients usually they will give a history of being to a bat cave, and then they would have inhaled. And mostly you just need steroids. You may not even need antifungals for this patient. However, if your inoculum is very, very high, or if you have altered host defenses such as HIV or AIDS, you may suffer life-threatening progression or reactivation of latent foci. So you can see there's that element of reactivation, just like for TB. So they may either progress very quickly or reactivate a latent foci of infection. In areas that are endemic, when they've done histoplasmin skin tests, they found that actually 80% by the age of 20, they are positive. So meaning you're exposed, but because your immune system is able to fight it off, you're fine. And usually it likes the lungs, okay? You get it through inhalation of the conidia that I showed that convert in vivo into the budding when they are budding. So dissemination to the highland, mediastinal lymph nodes, spleen, liver, bone marrow, brain may be life-threatening in infants and other immunocompromised patients. In our setting, HIV patients. And you can see the way it disseminates. It sounds just like TB. And also, it is characterized by intracellular growth of the pathogen in the macrophages and the granulomatous reaction in tissue. So it's almost like I'm describing a TB here. And these foci are what reactivates and codes dissemination of the fungi to other tissue. So the patterns of primary infection and reactivations are similar to those of TB. And co-infection has been reported to in as much as 15% of these patients. It may be associated with chronic inflammatory process known as a fibrosing mediastinitis. So you end up with scar tissue forming in response to Histoplasma capsulatum. There are other species, but I'll just focus on this. And it may end up encroaching on vital structures. So herein lies our problem. In a systematic review that was done in 2018, I believe, they looked at the distribution of reported cases of histoplasmosis across Africa. And there you are. Can anyone comment on Zambia? Any thoughts? Please just unmute your microphone. Any thoughts on this map? Actually, I've put the answer there.
Yeah, so any thoughts regarding the map
they are showing the distribution of histoplasmosis. What is the distribution of plasmosis in Zambia? What is the prevalence? What is the epidemiology? Can anyone just unmute their microphone?
I think it's unknown.
Thank you very much. Who's that? Sorry, they didn't introduce themselves.
Liamba.
So could you just introduce yourself?
This is Franklin Liamba, a registrar at Living.
Okay, thank you, Dr. Yamba. And correct, a gold star for you, because we do not know the distribution. And you can see, so do a lot of other African countries, but look at countries like Nigeria, if you can put the pointer there, you can see that they reported more than 100 cases. But interestingly, the data they submitted was before HIV, because before the AIDS epidemic. But if you look closely at Cameroon, you can see it's saying 11 and 20. Over here, there's a table. There's a key there. Yeah, 11 to 20 cases. However, in a recent study that was done in Cameroon, their prevalence in people with HIV was as high as 26%. And in those with advanced HIV disease, it was as high as 13%. And these are not small numbers. So I looked closely at this map and said, okay, maybe this is a West African phenomenon. It's not a Southern African phenomenon, but you can see South Africa has reported cases of histoplasmosis. Zimbabwe has reported cases of histoplasmosis. We do not know the epidemiology in Zambia. I do not want to say that likely it is there, we'll remain it as an unknown, but it's an area worth exploring because I'll explain why, based on the World Health Organization recommendations for 2020. So you can see in Nigeria, they found a prevalence of around 7% over here. I should have highlighted that, 7.7%. But interestingly, a study that was done in Ghana, next slide. A study that was done in Ghana actually found that they had more histoplasmosis than crypto in Ghana. And these are figures that are not very high. I think it was 4.7%, while crypto prevalence was around 2.7%. But in countries like Guatemala, in Latin America, histoplasmosis is more common than TB, and their guidelines demand that you screen every patient with advanced HIV disease for histo. And it has actually been shown that you reduce mortality by 10%. Some good news, but there's a problem. Most cases of acute histoplasmosis, if you are immunocompetent, they'll resolve spontaneously. I mentioned if you've gotten a pulmonary, you inhaled something from bat, or if there was some excavation happening, usually that's when you get outbreaks. You may need steroids. However, mortality has been reported to be as high as that of TB among those with advanced HIV disease. So that's a problem, and that's why this is of interest to us. I'll now go into the WHO guidelines and what our advanced HIV disease guidelines say about the deep mycosis.
Okay, so this brings us to our second poll question. And just give me a second to launch the question. Okay, so our second poll question reads, the fungi H. capsulatum, so these are facts about it, pick the incorrect answer. So A is pulmonary infection does not convey protective immunity. Option, hold on. Sorry, the question is, which of the following systemic mycosis is often associated with the skin and bone lesions and is more common in male patients? A, blastomycosis.
Go ahead.
B, coccidiomycosis. C,
It's okay. It's okay.
cryptococcosis, and D, histoplasmosis. So which of the following systemic mycosis is often associated with skin and bone lesions and is more common in male patients? A, blastomycosis, B, coccidiomycosis, C, cryptococcosis, and D, histoplasmosis.
Okay, so I'm sure you have noticed that the poll questions we've put up are not the same as the ones that are polling. I think it's a technical issue. What I will do is I'll address both of them very quickly. So the one that you are polling on is asking which of these is associated with the males and skin and bone.
Mm-hmm.
I think this is interesting, but not for this discussion. Of course, it is important in advanced HIV disease, but I was worried about information overload because I actually had a patient with blastomycosis, was male, he had skin and bone lesions. So for sure, blastomycosis is very common in the males and causes skin and bone lesions. The one of interest, however, is the one that we have up there. So we'll end this poll. And I'll just talk through the options after Naik reads them.
Okay, so the question reads H. capsulatum, facts H. capsulatum, and you should pick the incorrect answer. So the options are pulmonary infection does not convey protective immunity. That's option A. Option B, solid organ transplant recipients are not at risk. Option C, in highly endemic areas, more than 80% of persons are infected by the age of 20 years. Option D, chronic steroid users are at risk. And option E, histoplasmin skin tests can be used to determine exposure. So what is the incorrect answer?
So everyone gets a gold star because we haven't polled it. It's probably down there if you look. But so the incorrect answer here is B, because solid organ transplants are at risk just as much as those that use chronic steroid, and of course, particularly people with advanced HIV disease now setting. Importantly, just like TB, unfortunately, histoplasmosis does not convey protective immunity, just like Cryptococcus. And you can do surveys, the way we do sero surveys to determine how much COVID is in the community. They use histoplasmin skin tests and test the whole population. And you can tell the prevalence of the disease. But now the common thing is to use serological tests or urine antigen tests. I'll talk about that in a minute. So now to contextualize histoplasmosis, which is an invasive fungal infection considered to be endemic in the Americas and Africa, where we are, and Asia. It was actually defined as an AIDS-defining disease in 1987. I'll let everyone unmute their microphone, those who may be interested. Does anyone know the eponym for histoplasmosis? Does anyone know it? I'm not going to ask Naik because I know he knows it. Can anyone volunteer or quickly look it up? The eponymous name for histoplasmosis. I actually found it in my notes. I didn't even realize I learned it. Do we have any takers? The eponymous name for histoplasmosis, essentially the other name. Do we have anyone who has managed to Google it? So the eponymous name for histoplasmosis is actually Darling disease. It's not a very darling disease, by the way, but that's the name they've given it because of the person who first saw it in the lab. And its incidence in patients with the incidence of this disease is actually can be as high as 25% in people with advanced HIV disease. In 2020, the World Health Organization partnered with the Pan-American Health Organization to publish its first guidelines for disseminated histo among persons with advanced HIV disease. They also have included recommendations for diagnosis. Some countries, particularly in Latin America, have added it to their AHD package. You know how in our package we have CD4 count, we have a serum crag, we have a urine lamp. For them, they have added it. Anyone with a CD4 less than 200 or has AHD, defining disease, which is clinical stage 3 or 4, should get a test for histoplasmosis. And the yield has been very high in Latin America. Unfortunately, this is one of the key points for today, is that in areas where you have limited diagnostics, it is often misdiagnosed as TB. Personally, I have sent samples even to private labs and I've never gotten a result back. So that's a problem. My friend who's from Uganda said he did have a patient who had an infection all the way up to the nose and an x-ray that was suggestive of TB. When they did the biopsy, it was actually histoplasmosis. And I know we see this clinical presentation in a lot of questions. We will now move on to our third poll question. I hope it was...
So our third poll question is histoplasma is commonly misdiagnosed as TB. Just gonna launch it. I hope.
It's there.
Yeah, I hope our poll questions have been a little mixed up. So okay. Oh no,
No.
not the one.
So we can just ask somebody to unmute.
Yeah.
You can close that one.
I'll end this poll. So anybody to answer, histoplasma is commonly misdiagnosed as TB.
It's true.
Okay. Thank you very much. We can quickly move along. So I'm going to show a case vignette. The case. So this gentleman is, I'm sure you're aware that in Latin America, they do have individuals who actually look just like us, particularly in Brazil. So this man with advanced HIV disease presented with a CD4 of only 13 cells per microliter, which is not uncommon in our setting. So he presented with a 2-week history of progressive diffuse papular rash, as shown over here. So as shown over down there, you can see this rash. He also had the fever, he had hypotension and dyspnea. Do we have any volunteers, any thoughts of what this may be? On the right, you can see his X-ray, and up there, if someone can comment what they're seeing around his mouth, I think that may be helpful, but I believe these pictures are quite clear.
Okay, so any takers for that?
Any thoughts? Yeah.
Any thoughts regarding what you're seeing and the case vignette? Kindly unmute yourselves. Thanks.
SJS.
SJS, thanks, and that's a good differential. Thanks, Mikkel.
And I would agree with you. If you said that on my word, or I would say, this is Kaposi sarcoma, biopsy it away, you know. Any other takers, even looking at the X-ray, any comments? And I would like if somebody can just comment about the mouth.
Any comments on what you see on the mouth?
Okay, so around the mouth, you can see that there's edema that almost looks like the anthrax pictures we showed the other week. But you can see that he has, I'm sorry, may I use the point? He has mucosal lesions. Can you see that almost like dry blood? He has ulcerations in the mouth. Okay, I almost said the answer. I just, you know, so it can look like a Kaposi sarcoma, and you can see this miliary picture. You know, so you would think this is a TB, this is a Kaposi sarcoma. Even if the biopsy comes back negative, it's very tempting to just go ahead and treat, and I'm sure he would be on ATT. But this gentleman actually turned out to have histoplasmosis, and they did a biopsy. We can go to the next slide. So here we are. I wish we were in the same room. I would have liked us to discuss this. So this is histoplasmosis on the left in the gentleman above the lip. You can see that solitary lesions. These are the ones they'll tend to resolve on their own, but there's also a risk of recurrence of this type of histoplasmosis. These are usually immunocompetent. And then you can see in this, I like the way Dr. Naik is pointing that. I don't know, how would you describe that lesion in this young lady? Any differentials for the lesions we are seeing on the
upper right corner of your screen?
In the context of HIV and outside the context of HIV? Please just unmute your microphones.
Any takers, just to describe what we're seeing on the upper right hand of the screen?
Hello, Chair.
Hi, thank you, Chikondi Zulu. You may go ahead.
Yes, I think it looks like something like smallpox, or Yeah, some form of like that.
Great. Yeah, smallpox,
Yes.
that's a good differential.
Another differential, molluscum contagiosum.
Excellent, thank you.
Any other ones?
I think this one we can also mix taken with the epizoster.
Epizoster, thanks,
This
Mwewa.
one, this one, I think you mean
Cutaneous.
the girl on the right, I think it's very atypical, but yes, maybe an early one or a very early disseminated epizoster, if these are vesicles. Okay, I see what you mean. Please go ahead.
Liamba, you may go ahead.
It could also be cutaneous cryptococcosis.
Good, cutaneous crypto, thank you so much for that. Dingy, Chisi.
Yes, good afternoon. To me, it seems like another differential is contagiosum.
Exactly, molluscum contagiosum.
Molluscum, okay, great.
So it looks like a lot of things that we
Yeah.
see on our wards, doesn't it? And also, I thought you'd say mpox because we've eradicated smallpox, right? Even mpox.
Right.
I know when there was a pandemic of sorts, everyone would have said mpox, but for sure, it looks like molluscum contagiosum. It looks like cryptococcosis on the skin, but that is a case of actually histoplasmosis. So if you see such patients, suspicions of index should be high. I'm reluctant to offer a lot of diagnostic recommendations because we are still limited in our country, but you can see that turned out to be histoplasmosis. These images are from Latin America. I just wanted to draw your attention to the pictures at the bottom. This is something you'd see, a KOH prep. You can see that very thick birefringent wall, like the way crypto would look, right? And you can see that it's budding off, And this is happening in somebody's body. And it likes to also go to the alveolar macrophages. If you see such a picture, it's very easy to mistake it for leishmaniasis, actually. But that staining is distinct and they are bigger. You know, remember they are mastigotes. So then I want to draw attention to the top picture. What sample is that? Any takers?
Any takers for that top?
Yes. What specimen is that?
Picture. Are you able to see the pointer?
Oh.
Okay, so what specimen do you think this is here?
Any takers? I know we have a lot of MMeds and STP, so I mean, you can see some cells there. Where do you think this was taken from? Which tissue?
Things that blood.
Thank you.
Good, thanks.
Blood smear, right? So if you are unable, you don't have your diagnostic test and you suspect it, you can actually do a peripheral blood smear and request them to stain it and look for it. And they may be able to find it. Obviously, it requires a certain level of skill, but with time, as we know our prevalence, if a study is done, we may be able to develop this type of capacity. So if you're in a 4F area, you can ask them to actually do a peripheral blood smear. So histo is mostly found in decaying soil, most, and also it's the bats, they carry it in their guts. The birds carry it on the feathers. The causative fungus is Histoplasma capsulatum var capsulatum. There's also Histoplasma capsulatum var duboisi. I'm not discussing that one today. Mostly it's worldwide, and studies have been done in North America and Latin America. The primary route of acquisition is inhalation. Unfortunately, it's not protective. Once you have an infection, you are prone to a next one. The good news is there's no person-to-person transmission like TB. So that is assuring. So we expect if we do find it, it will have certain hotspots. In Latin America, it tends to be in people that work in the jungle. So like Lesh, they'll have that history of having worked in the jungle. So you have this type of hotspot distribution. I think we've talked about the site of infection. We've talked about AIDS. So patients with HIV will have what we call PDH, which is progressive disseminated histo, and will tend to occur at a CD4 less than 150. Just like if you see someone with molluscum, you know that likely their CD4 is less than 50. The severity of symptoms and the signs, they will usually mirror your level of immune competence. And in the non-immunosuppressed host, you can get this chronic PDH, and the way it's treated is actually very different. And most of these forms are characterized by lymphadenopathy, hepatosplenomegaly, skin and mucous membrane lesions, and some people may even have adrenal insufficiency and hypercalcemia. So when you see this adrenal insufficiency and hypercalcemia, you should start suspecting DH. But unfortunately, this looks like patients we see. So to differentiate it from TB requires a lot. So in the context of advanced HIV disease, coming to some issues that are programmatic, the three top killers are TB, cryptococcal disease. There's now severe bacterial meningial infections as number 3. I'm sure we are aware of that. Then now histoplasmosis has been added. What is suspicious about this picture? Are there any things that jump out? Any observation about this? This little pictogram that's up on your right. Anything, any comments, anything somebody would like to say?
Any comments from the network regarding this pictogram? So we see that there's TB, okay?
Hello, so I'm seeing histoplasmosis as being a small portion, or not like noticed, not easily noticed, like the way we actually pay attention to TB, cryptococcal disease, and severe bacterial infection.
Well, yes, I think I tend to agree with you. I think you've picked up part of it, but anything else? I noticed your name is McDarlington. Interesting with the topic we are discussing today. You will never forget this.
True. Not
Okay, okay, so you can see for Easter, we don't have a figure there. And for severe infections, you don't have a figure, but crypto and TB, you can actually measure the number of cases. Of course, the picture is never complete, but even in our guidelines, when we teach about severe bacterial infections, you discover that it's actually quite complex because you start talking about antimicrobial resistance, and it goes back to the key issue with this disease. You need to be able to make a diagnosis for you to quantify. So your lab capacity is very key for you to get the epidemiology of a disease right. We can move on. We can just scroll through because I've already talked about this. So we have a poll question. I hope this one was correctly loaded because it's my favorite poll question. Please note, it is not a knowledge poll question at all. You don't have to have known anything about histo. However, if you have a copy of the Advanced HIV Guideline as a soft copy or a hard copy, I've seen some mentors, I know they have them, so this should be easy.
Great, so the question reads, which of these is false regarding the Zambia guidelines for management of advanced HIV disease? This is the February 2021 guideline. So which of these is false regarding the Zambia guidelines for the management of advanced HIV disease? We have option A, pulmonary histoplasmosis, aspergillosis, and blastomycosis are mentioned. B, histoplasmosis is the most common endemic mycosis in AHD patients, is a statement in the other opportunistic infection module. C, fluconazole can be used to treat pulmonary aspergillosis. And D, colonization or contamination does not occur with blastomycosis. So which of these is false regarding the Zambia guidelines for management of advanced HIV disease.
Just a reminder, this is not a knowledge question per se.
Yeah, this is not a knowledge question, and your responses remain anonymous. So we don't know, we can't pick out who's answering the question. So please feel free to answer the poll question that's been given to you. So far, we have a very few number of patients of the network that have attempted the question. Let's all get answering so that we all learn. This is a learning process. Okay, so I'm going to end the poll question here. So, Dr. Fwoloshi, interesting results. We have 47% that have opted for option D, which is colonization or contamination does not occur with blastomycosis as being false. And then 24% opting for histoplasmosis is the most common endemic mycosis in AHD patients. Is a statement in other OI modules. 18% that have opted for pulmonary histoplasmosis, aspergillosis, and blastomycosis are mentioned, and 11% for option C, which is fluconazole can be used to treat pulmonary aspergillosis.
So just a check. Thank you so much, Naik. Maybe I should zero in on the answer quickly. Just a check that we all have those guidelines up there, the Zambia guidelines for the management of advanced HIV disease. I think if you go around to page 46, 47, you'll find most of these answers. They are there. So they are actually mentioned in our guidelines. Pulmonary aspergillosis, they are there in our guidelines. However, we have not made specific recommendations for testing because obviously we have diagnostic limitations. We have mentioned something about the treatment, and that statement is correct. We do not use fluconazole for pulmonary aspergillosis at all. For the others, you can try when you are really desperate. For pulmonary aspergillosis, you can't. I know for blasto, we use itraconazole or Ampho. But I needed to discharge a patient, and we ran out of itraconazole. That was four years ago, and we used fluconazole with very good results, but he was immunocompetent. Blastomycosis, you never get colonization or contamination. If you grow it, it's disease. But the whole point is actually not to see your knowledge, it's just to say that your guidelines, they comment about these mycosis, the deep fungal mycosis, the deep mycosis. It's there in our guideline. Please take a look and take some interest. It's not detailed. Maybe in the next guideline, we may get some detail, particularly on histoplasmosis. So I'm going to talk about the tests that you can do. You can do a culture. If we have any microbiologists around among us, they'll tell you about, you need the BSL-3. You don't want people to get infected from the spores because you just have to inhale them. You can do antigen detection in the urine and blood. This test is what is now being commonly used across the world. Then you can do serological tests. I put my surveys for histoplasm in there, but those are skin tests. You can do antibody tests, but they are notorious for some cross-reactivity, so you have to be aware which fungus cross-reacts. I personally like histopathology because the first case of blasto I saw was because histopathology picked it. So you may not have these fancy tests, but histopathology saw the big copper coin yeasts for blasto. So you can send it in for histoplasmosis, for histopath. You can send in a bone marrow, lymph nodes, lung, liver, and consider doing a peripheral blood smear if you have a very good lab scientist. They can help you find it in a blood sample, particularly if you have someone, they look like TB case, but everything is negative. You can talk to your lab and they may be able to do this. Of course, PCR is available, though no approved standard. I think we are all aware that there is a package of care for advanced HIV disease, but each country decides what goes in that package of care. They can only recommend. As I mentioned, there is proper guidelines for diagnosing and managing disseminated histo. The World Health Organization launched these in 2020. Their target was particularly Latin America, but with the studies that came out of Ghana, Nigeria, and Cameroon, there is a push for some African countries to start considering adding histo. So these are the tests that would be in your package of care. So aside your standard, your urine lumps, your cracks. If you have a patient who's very unwell with AHD, you want to be able to do a point of care Visitec CD4. I believe Zambia will start doing those. They are qualitative, not quantitative, so they give you a range, but there you go. So it can distinguish someone with a low CD4 count from someone with a high CD4 count. So this is an ideal package of care. I'm happy to say for Zambia, we have the 3, and we are getting the 4th, which is the CD4. The histoplasma antigen, look how easy it is. It's just a drop and you know. But obviously you got to do validation. You need to understand the epidemiology in your country, because if it's at 0, it may not be worth us investing money in. So we don't have that in our package. Just to mention that we need to keep a close eye on advanced HIV disease, and we need to monitor it. Remember that the 1995 cascade does not count people who are unwell. And this is one of our indicators where we are not doing very well. So we have impact indicators, which are your HIV incidence, and the other one is mortality from HIV-associated disease. And you can see that, again, HIV still accounts for most of the deaths in Zambia, HIV-associated disease, with a very small annual change in we are not improving much, just like 0.89 decrease. So we are not doing very well with our indicator for advanced HIV disease. And this could be some of the reasons. Aside TB, crypto, bacterial infections, I think, are struggling. I think fungal infections, even at UTH, we don't make much this diagnosis often. It's mostly just cryptococcus and candida. So in terms of the summary, they can occur as primary infections, or they can be opportunistic infections. Histoplasmosis has been reported in other parts of Africa. In Zambia, we do not know our burden. So right now, I'm looking for somebody who has made this diagnosis in this country, and I haven't managed to get anyone to say they've managed to get a test positive or from the lab. So primarily it causes pulmonary disease. If you're immunocompetent, it will tend to resolve spontaneously. You may need steroids. Unfortunately, in those with HIV, it's actually age-defining and has a high mortality. In some cases, particularly where you do not have adequate lab capacity, it can be misdiagnosed as TB. Countries must ensure they understand the epidemiology in order to make appropriate guidelines for the population with advanced HIV disease. We could repeat the polls, but I acknowledge that they were poorly loaded. So at this point, we could just, I think, close and go into a Q&A, because we are past our time.
Okay, thank you so much, Dr. Fwoloshi. That was a really nice presentation. Sorry, let me just. Here. All right, so thanks once again, Dr. Fwoloshi. That was a really amazing presentation, and so much to learn from. And I mean, just a small summary on it is, you've already given a summary, but the most important thing is that we should know that histoplasma can actually, it's a mimicker of TB. So you can have, I'm sure a lot of us have come across cases where we've clinically diagnosed TB, sputums have been negative, your LAM has been negative, and you still decide to go and treat with TB treatment, but the patient doesn't resolve. And these are potential histoplasma cases. I don't know if you agree with that. So that's very important to keep it in your differential diagnosis and look out for it. It's just soon we'll probably have diagnostic tests for histoplasma in the future, which will be nice. So at this point of time, I'd like to open up to questions or contributions from our network. Kindly post in the chat box, or you may raise your hands and we may be able to attend to your question. So network, kindly unmute your microphones and ask your questions. Okay, so we've got one hand.
We do this just to mention that Dr. Chitalu is also on, in case he wants to comment, and Makai.
Okay, so hi, yeah, Dr. Chitalu, Dr. Makai, any comments? We've got a question from Roy. Roy, you've raised your hand. You may go ahead and ask.
Good afternoon, Dr. Fwoloshi. Thank you so much for this wonderful presentation. my question, I think, is just a follow-up on the peripheral blood smear. I think we saw, of course, there's some segmented neutrophils, but I think I missed you on what's the a characteristic feature that you look for
You can actually see
that will point to.
you can see the dark staining yeast that look black purple. If you struggle, I think the lab can help you. So the dark purple, I think you can see it in the macrophages as well and the bone marrow. So you look for the yeast, essentially. You look for the yeast because it's in vivo. So when it's in the human body, the temperature is above 37 degrees, it's a yeast. So you look for the yeast.
Thank you so much.
No problem, Roy.
Great. So that was Dr. Roy Tepa. Any other questions? We have a comment. How can we access the presentation? So Savia Kunda, all these presentations will be available on the iEcho platform. And I'm sure IT will inform you on this in a bit. So the presentation will be shared on the iEcho platform and will be available to the entire network that has attended today's presentation. Any other questions or contributions? Our panel of experts, Dr. Chitalu, Dr. Duncan, Chanda, any questions? Any contributions towards today's presentation? Dr. Andrew Zulu, Dr. Makai. Okay. So we have, Dr. Chitalu, you may go ahead and unmute yourself.
Oh, thank you so much. I think I've enjoyed the presentation from Dr. Fwoloshi. It's been a very good reminder for all of us. And I think it has set a very good stage for probably more in-depth look at endemic mycosis. I just wanted to remind ourselves, I think with Dr. Fwoloshi a few years back, we saw a young boy that had come in with swollen lymph nodes and had been on ATT for quite a while with no improvement of the lesions and presented with these ulcers and swollen neck. And we had a biopsy that was done and the confirmed blastomycosis. And it was very good learning curve because we didn't have the ideal treatment for that particular patient, but we had to make a nice cocktail. And this patient responded to the treatment, has improved HIV treatment, also recovered. So really, if you've never seen it and you've never heard of it, you never think about it. For me, it was a learning case. But the first case I actually saw it back at UTH. The patient is still alive now. So please let's think about endemic mycosis. I think the fact that we haven't diagnosed it doesn't mean it's not there. We need to think about it, especially if our patients are not responding. And let's consult. I think we have a good platform for consultation, such as the iEcho 7040, as well as just referring and just engaging others who might have seen the case. Other than that, I think I've enjoyed myself and I've learned a lot. Thank you so much.
Thank you so much, Dr. Chitalu, for that contribution. So we just have one question in the chat box. In cases of advanced HIV, if we have a client who has been tested positive for TB, do we interrupt the ARV treatment or we should go ahead and treat the TB?
I'll give that question to you or Dr. Makai. What do you think?
Okay, so in cases of I'll read the question. In cases of advanced HIV, if we have a client who tested positive for TB, do we interrupt ARV treatment or we should go? So this depends on whether the patient is treatment naive or has discontinued the ARV treatment. So if the patient is already on ARVs, then you should go ahead and treat for TB. If the patient has not been on ARV, you may start the treatment, but it has certain conditions. If you have disseminated TB, if you have TB meningitis, you need to delay the initiation of ART in that case, according to your guidelines. So in such cases, you want to delay your ART initiation and start the TB treatment first in order to avoid IRIS.
I think that's a great answer, Dr. Naik. Mapalo, I really like your question because I was trying to divide this presentation in future from clinical presentation, diagnosis, and management. But I pick out something interesting from your question. In Zambia, we say that the two forms of OI is that you should delay ART in TB meningitis, as mentioned. So people with TB and advanced HIV, they need ART immediately. Unless, as Naik has mentioned, if they have TB meningitis or cryptomeningitis, and the other one is actually histoplasma meningitis, you delay. The only thing is that we don't test for histoplasmosis. So we are just doing a primer so that in future, you know, usually actually like the blasto Chitalu mentioned, the diagnosis didn't come from us. It's the lab that told us that what you guys have there is actually blasto. So we are hoping one day we can at least do a study and check if we have history in our country. If we do, then we can make policy recommendations. Mapalo, I love your question. So histoplasma meningitis is the other OI in which you delay treatment of HIV.
Okay, thank you. So I hope that answers your question. Okay, so it seems like there's no hands raised and there's no other question.
Something, can you?
Okay, so Lindiwe Ndlovu has a comment to Mapalo's question, and she says you can resume after 2 weeks. So again, yes, you can't stop the ARV treatment and then resume after 2 weeks. In that case, you continue the ARV treatment and initiate on TB treatment.
Please do not interrupt ART until you are very sure. As Dr. Chitalu has mentioned, 70-40 is always open. If you are not sure, please do give us a call.
All right, thank you. So just a shout out to those who've joined us today. We've seen a number of people that have joined from Petauke, from Luwingo. Thank you so much for joining us. And then I see there's Dr. James Impungwe from CDC. Thank you so much, sir, for joining us today. We have, yeah, so thank you all. Thank you to the network. It's 4 minutes past 1, and I think we've come to the end of our session. Once again, I'd love to thank the presenter. This was such a powerful presentation. Thank you so much for giving us this talk on deep mycosis and narrowing in histoplasma, Dr. Fwoloshi. We really, really appreciate you. So I'd like to thank the IT and coordination team for today's presentation. And yeah, lastly, I hope you all have a great day, and we'll see you in 2 weeks' time for the next AHD echo session. All right, good day, everybody.